So thank you for having me here today. I'm pleased to talk about some of my own clinical practice in treating patients on antivirals, and I'm going to work through some cases today to highlight some of this. These are my disclosures. And just a bit of an introduction. So we're predominantly talking about Paxlovid today. So Normatravir is a CYP3A4 substrate and PGP substrate that undergoes renal excretion. However, it's the ritonavir, as you know, that causes all the problems. Ritonavir is a potent inhibitor of 3A4, 2D6 and PGP, metabolized by 3A4, and these are significant for Paxlovid. So the inhibition interaction, so the inhibitory effect of ritonavir can occur within 24 to 48 hours. So when we're talking about a 5-day course, these are really important and we need to be aware of them. However, ritonavir is also an inducer. It induces 1A2, 2C8, 2C9 and 2C19. However, induction interactions can take up to 14 days. So a big difference here with regards to HIV and hepatitis C use of ritonavir is that in Paxlovid for 5 days, the induction effect of ritonavir is not significant. And that's why there'll be some differences between the HIV and hepatitis C recommendations for ritonavir versus the Paxlovid website recommendations on the COVID website. So it's due to the induction, the differences in the induction. So induction interactions, however, caused by inducing co-medications such as carbamazepine are significant. So very quickly, just dosing and administration, because it will come up in the cases. So moderate renal impairment, we have a dose change of half dose Normatravir. It's not recommended in severe renal impairment. In hepatic impairment, it's just Child-Pugh C liver disease. It's not recommended because it wasn't studied. So no issues in Child-Pugh A or Child-Pugh B. Taking a drug history is, of course, the most important thing when we're managing Paxlovid drug interactions, and in my setting it's entirely led by pharmacists. So we've written over 1,000 prescriptions now for Paxlovid, and it's been managed and prescribed by infectious disease or local general practice primary care pharmacists. So key to all of that is, of course, understanding if there's any drug interactions that we need to be aware of. What are the over-the-counter medications our patients on? Are they taking any recreational drugs? Are they on specific hospital-supplied medications such as systemic anti-cancer therapies, OST, short course, long course, bloodborne virus treatment, contraception, etc. So key to everything is an important drug history. And of course, patients are on more than one different thing, often prescribed by more than one doctor. So it's important that we know where to look. And the Liverpool drug interaction website, if you put in all your medications, then of course you'll get the summary of recommendations that everybody will know well from our HIV, HEP and cancer websites. The managing of drug interactions, though, is different with COVID, Paxlovid, particularly because of the 5-day course. So previously, if you saw a red interaction, then that would mean not recommended or contraindicated, and therefore you would need to find a different co-medication. And what's different here, however, is because of the 5-day course, whilst that data is still correct, you can consider stopping the co-medication and restarting it in the 8 days. So red does not automatically mean that you cannot give your patient Paxlovid, and that's really important because it's the most effective oral antiviral we have at the moment. So if our patient is on something like simvastatin, we can stop it and restart it in 8 days. Again, it's important to read what we're saying in the summaries. So for other drugs like amiodarone, where there's such a long half-life, stopping it will make no difference. So in the case of amiodarone, that is a contraindication and you can't use Paxlovid. So important to be aware of the difference. The amber interactions, again, there's often something that needs to be done to circumvent the interaction. But what we don't know is about the patient in front of you. So it's important, again, to understand the advice and take it looking at the patient. That is the patient, for example, a healthy 18-year-old on no other co-medications, Or are they a 75-year-old patient on significant polypharmacy with already pre-existing renal or hepatic impairment? And often how we make a recommendation depends on these factors. So can the patient be counselled to manage side effects? If they get hypertension, can they understand what you're advising them to do if that happens? Are they receiving their medicines in a dosette box? So for example, you're not going to tell a patient to stop taking their amlodipine 10 milligrams, but it's in a box of Monday, Tuesday, Wednesday with 20 other tablets that are the same colour. The patient is at home with COVID. They're not going to be able to do that themselves in a majority of cases. So again, really important to know the patient in front of you. Can they stop the drug? In many cases, the answer is yes. Keep it simple is really important when managing Paxlovid interactions. We're dealing with prescribers who have never managed ritonavir before. We're dealing with patients who are at home with COVID. They're not coming into hospitals. We don't want to see them in clinics because they've got COVID. We want them to manage things as quickly as possible at home. If a dose change is the only way to manage their interaction, I've put a tick in a cross here, because for some patients that's not going to be possible. You know, we can't if we can't half the dose, if we need a new strength, can you do that very quickly? And in some cases that will be no. Other patients, yes, we can perhaps deliver out a new dose of tablets. Can it be safely stopped? So safely is important. Can they understand what's to be stopped? And can we counsel on managing side effects if needs be? So I'm going to look at some of these issues through some cases, some quick cases, just of a variety of patients that I've seen in my own practice. So this was a 33-year-old female with rheumatoid arthritis, asthma, and some depression. She was on adalimumab and methotrexate, folic acid, and some inhalers. And importantly, before we start thinking about drug interactions, our local guidance and certainly the same with many national guidelines I've seen is that patients with immune modulatory disease can temporarily withhold their DMARDs, their biologics, their JAK inhibitors until the antiviral course is complete and the symptoms are improving. So the decision in this patient in the first instance was just to hold the methotrexate and adalimumab. What about the Fluticasone inhaler? Anybody that's worked in HIV will know that with ritonavir, this interaction is a red. So, however, again, going back to the 5 days in Paxlovid, we feel that looking at, although that fluticasone is a CYP3A4 substrate, the elevated corticosteroid levels that lead to Cushing syndrome and adrenal axis suppression we're not likely to see in the 5 days. That's not going to happen. So therefore, this is a green interaction. This patient doesn't need to do anything. They can keep taking their inhalers, and this effect with it 5 days of ritonavir is not going to be a concern. This patient was a 75-year-old male. He had cirrhosis, diabetes, hypothyroidism, and the medications here on are very typical for many, many patients that we all see. Metformin, simvastatin, levothyroxine, amlodipine, lisinopril, and aspirin. I mentioned he's got cirrhosis, but if you look at his bilirubin, his albumin, he's got a normal coag. This patient does not have Child's C cirrhosis, so therefore there's no issue prescribing Paxlovid. We can go ahead. What about the drug interactions? Well, there's an amber for amlodipine. I'll mention that, and a red for simvastatin. But first of all, levothyroxine is something that we got questions about. So it's partly metabolized via glucuronidation, and there are some case reports of hypothyroidism with regular ritonavir more than 4 weeks. So again, we're looking at long-term data in HIV. Again, the induction of glucuronidation takes several days. This is not going to be a concern in a 5-day course. So this is a green interaction. There is a mention of levothyroxine in the Paxlovid license, but again, if you look at the wording of it, it says it recommends monitoring in at least the first month. So again, that's taken from data in long-term use of ritonavir. So this patient, no issues with levothyroxine. Amlodipine, there is a pharmacokinetic interaction. We have a 2-fold increase caused by 3A4 inhibition with ritonavir. but this is entirely manageable. So again, this is not something that we look at and say our patient can't get Paxlovid. There's lots of different ways to manage this interaction. We can consider a 50% dose reduction. So if our patient's on 10 milligrams of amlodipine, perhaps we could give them 5 milligrams. But if that's too difficult in practice, then we can advise the patient to be aware of symptoms of hypertension and carry on as normal. If they do feel they're getting a bit dizzy, etc., then they can stop their treatment while they're on the Paxlovid. They could just withhold it for the whole 8 days if that's easier for them to understand and restart it, or they could consider alternate day dosing. So there's lots of ways to manage this interaction, and this is similar management strategies for all calcium channel blockers. And finally, simvastatin. So you can see it's a red, I mentioned that earlier. There is an increase in simvastatin levels with, of course, and it's a significant increase with an increased risk of myopathy, and it's an avoid. It's a contraindication. We don't want to give these two together. But for the majority of patients, statins can be safely withheld for the short duration of the Paxlovid and the 3 days afterwards. And this is the advice and the recommendations for the other statins as well. So this patient was entirely able to go ahead with his Paxlovid, which was the best thing for him. And we advised him to hold the simvastatin and amlodipine. Just to mention briefly about Clopidogrel, because again, this patient could have been on Clopidogrel, and it's something we see quite frequently. So we know, based on data in studying boosters of cobicistat or ritonavir in HIV, that there's a pharmacokinetic interaction with Clopidogrel and prasugrel, whereby the Clopidogrel active metabolite sees a decrease in the area under the curve of 69%, and similarly with 52% with prasugrel. So the active metabolite of Clopidogrel and prasugrel are significantly reduced by ritonavir and another booster, cobicistat. What does that mean for our patients? Well, this pharmacodynamic study looked at the effect of platelet receptor blockade measured by a Verify Now device, and what that showed us was that with Clopidogrel it was significant in some patients. So 44% of HIV patients on ritonavir did not achieve platelet inhibition. However, with prasugrel, all patients did. So that you can see the difference in effect, and prasugrel therefore should be the preferred choice over Clopidogrel in the presence of boosted regimens where possible. And that goes back to our recommendations then for Paxlovid, where in recently stented patients, we have advised against using Clopidogrel. However, in patients who are prescribed Clopidogrel for other reasons, such as aspirin intolerance perhaps, where a transient loss of efficacy might be acceptable, then we've put that as an amber so that you can consider continuing. So just to explain the difference there. And finally, this case for I guess food for thought and just something to think about as we move forward using Paxlovid. It was a 59-year-old male with a long-standing hypogammaglobulinemia, easy for me to say, splenic marginal zone lymphoma, and he was on rituximab in 2018, but he had a recent relapse and he requires rituximab again for hemolysis. Now, this patient was COVID positive on the 4th of January, PCR positive, strongly positive, with a CT value of 17, and again the CT value of 18 on the 29th of January. So this patient was not clearing virus. On the 1st of February, we gave him remdesivir, sotrovimab and Paxlovid at a reduced dose because he was in that CKD3 bracket, but he remained positive with a CT value of 30 on the 4th of March. So we looked again at this patient. He was just on the cusp of CKD3, so we decided to go for the full dose. So we looked at the data on normatravir, and we were happy that just because he was very close to the margin that to go with full dose, and we went for 10 days, and this patient did clear virus. But why is this important with regards to drug interactions? All our data is based on Paxlovid for 5 days, and that's because of we would not considered the effect of induction of ritonavir, because that is not going to be a concern within the 5 days. We've had 3 or 4 patients like this now, and we've considered and prescribed the 10 days of Paxlovid, and I'm hearing more and more conversations about this. So it's something we really need to be aware of going forward if larger courses of Paxlovid are being used. So again, important, our advice is only on the 5 days. And do we need to, and certainly the answer is yes, we do need to consider the effect of induction interactions in courses going forward. More than that, so likely 10 days is going to be okay. Beyond 10 days, then we do need to consider that with regards to drug interactions. Luckily, this patient, however, wasn't on any other interacting medications. So the key learning points are that Paxlovid is the most effective oral treatment that we have at the moment for patients with mild to moderate COVID, and the data we have suggests that it does reduce the risk of hospitalisation or death. So it's key that we can get as many patients as possible that qualify onto this drug. So it's important that we use our pharmacists, we use our doctors, and we can understand how to manage the drug interactions and not be scared of them, to get as many patients as possible on this. So potential for drug interactions does exist, but most of these interactions can be managed with the available tools and resources that we have available now. And many thanks to the website team, and I'm happy to take questions.